So thank you guys for joining. I'm really pleased to welcome you all today for a discussion on a topic that I'm really passionate about, which is diversity, but specifically diversity in healthcare. It's a topic that's been discussed in our industry for many years, but unfortunately it still remains a major issue in 2021. I think the disproportionate effect of COVID-19 on ethnic minorities has thrown into sharp relief the effects of racism and biases on health. According to Public Health England, people from ethnic minority groups are almost 3 times as likely to contract COVID-19 and 5 times more likely to experience serious side effects, outcomes, or death when other factors like age, region, or socioeconomic status are controlled for. Lockdown measures have also disproportionately affected communities. Those from Bangladeshi or Black African communities were more likely to have experienced financial insecurity or mental health issues than their white counterparts. From a communications perspective, a recent report found that key government public health messaging, such as stay home, protect the NHS, and save lives, was not reaching all ethnic minority communities. And this may partially be attributed to language barriers for those who speak English as a second language. And we are seeing lower levels of trust around COVID-19 vaccines, which is reflected in lower rates of vaccine uptake within minority and minority health worker populations. On almost all health measures, ethnic minority groups, especially Black and people of South Asian heritage, have the worst outcomes. And COVID-19 is just another example of this. While the meteoric rise of digital health technologies is driving forward the future of care, algorithms in AI health tech have also been found to perpetuate existing biases against minority populations. This lack of diversity also extends to the medical research community, both within academia and in clinical trial design and recruitment. The US FDA reports that only 48% of trial populations include women, 7% of trial participants are of African descent, and white patients comprise over 3/4 of trial patients. Obviously very concerning. As great leaps in our understanding of the human genome are rapidly expanding, our capacity to better tailor treatment to individual patients, a shortage of genomic research data in persons of non-European ancestry is also impeding our ability to use genomics in clinical care for those people. But despite all the challenges, you'll be happy to know that it's not all doom and gloom. Progress is slow, but it is being made. And so really what I wanted the conversation to focus on today is really how we can elevate the diversity agenda and talk about some of the action that's being taken within the health and healthcare sector, and specifically within communications. So I'm really pleased to be joined by 3 fantastic speakers who will be showcasing some of the great work that they're doing to move the needle. And I'm really looking forward to the robust discussion. I'm joined today by Leontina Postelniku, who is the Program Manager for Health and Social Care at Tech UK. She leads engagement with stakeholders, including the Department of Health and Social Care, NHSX, and NHS Digital. And she's also a former journalist, so she comes with that comms perspective as well, having worked for the Healthcare Information and Management Systems Society, which is HIMSS, as an associate editor covering EMEA for Healthcare IT News, Moby Health News, and HIMSS TV previously. Next up, we have Allison Kalu, who is the founder and president of Clinical Ambassador Holdings and I Participate. She's a patient recruitment consultant specializing in dynamic communications that bridge the cultural divide and break the engagement stalemate in clinical studies. She has over 20 years of experience in diversity, equity, and inclusion, optimized recruitment tactics and patient education campaigns, and she was previously the director of public relations for the American Social Health Association. So again, bringing that healthcare communications perspective as well. And finally, we have David Bartram-Shaw, who is the global head of data science for Edelman Data and Intelligence. He leads a large team of data scientists, data engineers, and researchers to build scalable and innovative data science projects within the communication space, and is going to be showcasing some of the cutting edge tools being developed to tackle algorithmic bias in the health and other sectors. So I'm really looking forward to what they have to share. And without further ado, I'm going to hand over to our first speaker, Leontina.
Thank you very much. Good afternoon, everyone, if you're joining us from the UK, and thank you for having me and for the warm introduction. It's a pleasure to be speaking with you today, and I'm really looking forward to the discussion. As you say, it's a topic that's very close to my heart, and it's a privilege to be on the panel along with David and Alison, and I look forward to learning from them as well. So as you've just heard, I represent Tech UK, which, as the name gives away, is the UK's Technology Trade Association. So we work with and represent the interests of over 800 technology companies that are spread all across the UK, which range from large multinationals to innovative startups. And here I work with the members that have an interest in health and social care. And essentially our aim is to show the power that technology has to drive progress, to deliver results, and to improve lives. And if we look at the past couple of months, we know that technology has played a key role in the response to COVID-19. So it's helped to support staff, if we look at primary care through the rollout of remote consultation capabilities, but also to support patients and the wider population more widely throughout the crisis. However, it's important to know that as technology becomes even more important in our lives, we need to ensure that it works for everyone. And this is something that we're focusing on at Tech UK. So what does this mean? Given the growing pressures that we know that the NHS is facing, so among others, staff shortages or challenges that are posed by an aging population, the health sector is increasingly turning to technology to care for citizens and to provide services that are fit for purpose. And I'm sure many of you on this call actually are probably working with companies that are providing a fantastic array of technology that can truly transform care and improve patient outcomes. But we're acutely aware of, and this is something that our president, Jacqueline de Rojas, who is a well-known champion for diversity in technology, she emphasizes that there is a lack of diversity among health technology innovators and technologies that truly meet the needs of the population. So we need to ensure that all voices are heard and included when it comes to designing, building, and testing technology solutions. And as you mentioned in the beginning, although we are seeing progress, we know that there's so much more that we can do. So if we take an example looking at gender diversity, women represent 47% of the UK workforce, but only 17% of the tech workforce. In addition, only 15% of the entire tech workforce actually comes from an ethnic background. And so this has got to change, and we have to embrace diversity in all of its forms. If I have to give you an example from the digital health and care space, an initiative that I believe is driving progress is the Shuri Network, which we in the Health and Social Care program at Tech UK have started working with recently. So the Shuri Network was launched back in 2019 with the aim to tackle biases by providing Black and minority ethnic women from across the health service with a platform to further their careers into leadership position. And this is because the research found at the time of the launch that there were only 10 Black and minority ethnic women in Chief Information Officer, Chief Clinical Information Officers, or equivalent role across the health service. That is despite over 75% of the workforce identifying as female and around 20% being. I do have to mention as well that we recognize that the diversity problem actually might be, when we talk about ethnicity, may be masked by the fact that people characterized as BAME are being grouped together, and we understand that this may not be a true representation of the different experiences that are in the industry. And going forward, we will be working to incorporate a language that truly recognizes the complexity of the issue. But if you are working with health technology companies, I would really encourage you to look at the Shuri Network, as they are planning to launch at the end of March a shadowing program where they will create opportunities for their members to shadow leaders, digital leaders, and essentially gain an insight into the different types of digital health and care careers that are out there. So with that being said, I look forward to delving into some of these issues a little bit deeper and telling you more about our work with our members. But for us, essentially, it is clear that to ensure that services are fit for purpose and fit for the future, the transformation that we will see in health and care will need to have at the core teams that are truly representatives of the perspectives, the needs and cultures of the communities that are being served. And that's both on the technology and the health service side. And so this is what we are pushing forward through our work on diversity and inclusion at Tech UK with our members. Thank you.
Thanks, Leontina. I mean, it obviously doing some great work there. And I think that feeds nicely into the topic that David's going to talk about, which is, obviously with the rise of health tech and health technologies, it's really important that technology reflects the people that use it and the diversity within our population. So with that, I know we're going to dive into some of these within the panel Q&A, but I will hand over to David to tell us a little bit more about how we are combating those types of biases.
Hey guys, nice to meet you all today. Let me just share my screen. So yeah, I work for Edelman Data and Intelligence, look after data science for us globally. And we've been working to just try and share my screen. Sorry. Here we go. Okay. Can you all see my screen? Good. Yeah.
Yes.
So yeah, we are basically the data research analytics arm of Edelman. And my team has been working to build some scalable products to try and use machine learning and data at scale to solve some of our problems within communication and help our clients to understand how to improve communications, how to respond to risk, how to react and understand trust and ultimately people and the people behind communications and our clients and you know, the merge of the two. And one of the things that I'm really passionate about is understanding how we can use AI in many different ways. And I think AI has currently got some bad rep for good reasons, I think, because there are many instances where AI has been biased and it's had a negative impact on the people that have been exposed to the technologies that encompass that AI unfairly. And I think what I wanted to do today is just run through where those biases come from. I think there are three key areas just to kind of, most of you might know this, but I just want to cover that anyway to get us thinking about how we can solve these things. And we all can. And I think that's one of the themes that I wanted to raise today, is that we all have the ability to help these machines to learn better. You know, we train them. And so, you know, they're only as good as their trainers. So we have to do a better job, and it's our responsibility to do so. And then towards the end of the presentation, I want to show how we're kind of flipping it on its head to actually use AI to uncover bias instead of being impacted by the bias that we find within machine learning algorithms. So the first area of bias comes from how data is collected. So the majority of AI and machine learning algorithms is supervised, in that we provide an algorithm labels from which it learns. So it could be images that are labeled with descriptions. It could be texts that are labeled with emotions. And so the labels have biases based on the people that are labeling those things. And so as we train the algorithms, they can only learn from what we provide them, the supervised ones anyway. So they are susceptible to the biases of the data that's collected. So one thing that we can do as a group, especially when it comes to healthcare, and I'll cover some of those examples later on, and the biases that exist, and you know, all of the great research that's been done in a study by study basis, is how can we take those and make sure that they're not present in how we train our algorithms and the data that we feed into our algorithms. So the first is the bias from the labelers and us as humans labeling. The second is the representativeness of the data that we feed into the algorithm. So that's a bias in the sample that we create. And I'm sure most of you have seen this example. It was by MIT, a study that was done on basically all facial recognition algorithms out there in the market from the tech leaders, and the performance against different skin tones. And what was uncovered in that study is that the reason for this is the unrepresentativeness of certain groups within the data that we train the model on. So it's been able to learn because it's seen more and more, in this example, lighter skinned males. So it can learn the facial features of the male. So it's not the algorithm doing anything biased, it's learnt the bias of you know, the sampling of it that it's been exposed to. And again, that's something that we can control for when we're training those algorithms. And one of the things that I think we struggle with is gathering that representativeness of those labels. Again, comes back to how we label data and what we train our models on. So these two things we're really in control of, I think. And there's a big push at the moment, and I think that there's, you know, more of a push in some areas than others, but these are in our control, and I think they will get better, and they are getting better over time. The third area of bias is in the context itself. So I'll talk about two types here, text and image. For text, the context of the words and how words are used in relation to each other. So the relationship between the words. And for images, it's the pixels and the relation that the pixels have to each other. And this little image at the bottom here of the guy and the 8 images I'll come back to in a minute when I talk about how we're kind of flipping it on its head. So we've got 3 types of bias. The first 2 we can control for, but we can't change the impact of those things. The third one, the context of the algorithms, we can actually learn from. So what we're doing, and we're not the first to do this, there's been a few papers that have been released on this, fantastic papers, and I don't know if we can share the links afterwards for you guys to read, but the example on the right there is from a paper that studied gender bias against lots of different things and in obesity. And what they did in the paper is they studied the words that we used around different genders. And the way that they can do this is every word within their algorithm is represented numerically based on a vector. So we have this concept of distance, and distance allows us to understand when he, she, her, his, words that are indicative of gender are used in relation to obesity terms. So you imagine this is obesity, but it could be any type of bias, because any word that's captured by these models have a numerical value, have a relationship that's gathered by the context of that algorithm. So we can start to look and feed in things that we want to search for. And the same is actually true for images. And again, I can share another great paper that looks at the pixels and the relationship between the pixels. And flicking back to this image here at the bottom, this one was from a paper where they had a generative algorithm that actually creates output, so it can create images or it can create words it's never seen before. And they fed in the image of a man's head, and they looked at the body types that were generated from the man's head. And you can see here, there's a lot of stereotypical body types in terms of what they're wearing, the jobs that these people have, that's inherent within that model and how it's trained. So it's not just text, but it's also image that we can learn from. So when we think about how we're trying to use this, when we think about from a communication standpoint, we can look at many things. We could look at marketing, how companies are talking. We can look at forums, how people are talking. We can look at studies, research studies, and uncover automatically the biases that exist within those studies by pointing at different corpuses of content. So when we think about some of the biases that exist in healthcare right now, and are backed up by loads of great studies, like the way in which women or men are issued pain medication, for example, and there's this bias towards sedatives for women and pain medication for men. That was done on a small scale study, but imagine if we could look at millions of people and how they're talking across the internet to uncover more biases that exist in how they're being treated, by different healthcare industries. And that takes us from a small scale study to a large scale study. So we tend to look at it on 2 different ways. One is a macro trend. So that's a corpus. If we want to look at a certain sector of the healthcare, or we want to look at a certain disease state, or we want to look at a certain type of service, we can point at specific corpuses of text and look within that text for bias. It could be interviews, it could be, as I say, forums on certain disease states. So to give us a view of within that corpus, what are the biases that exist? Then within that, we can go down and look at and surface the comments or the papers or the articles that contain that bias. So we can then, allow us as researchers to find the right content to look at and consume, and then maybe do a study on as a secondary piece to hypothesis through to research and study. So what we're trying to do is take AI and the biases that exist within AI and kind of flip it on its head and try and uncover these things at scale, using AI for good rather than being impacted by the biases that are inherent within how these algorithms learn.
Great. Thank you so much, David. I know we're going to come back to some of those points in a minute. But before I do, I would like to hand over to Allison, who's going to slightly change tack and talk to us about the importance of diversity as reflected in our clinical trials.
Am I unmuted?
Yes, you are.
Can you hear me?
Yes.
Can you see my screen?
Not yet.
Not yet. Okay. Now?
Yep, perfect.
There you go.
Okay. Greetings, everybody, and thank you so much, Char in particular, for inviting me today. I am delighted to be with all of you. I am the founder of Clinical Ambassador, a boutique patient recruitment agency based in North Carolina. We specialize in health communications that guide the interface between the pharma and research industries and communities of color to optimize the outcomes for all stakeholders. But addressing disparities drove my entrepreneurship, with advocacy as the cornerstone of our mission. We are currently evolving the brand to lead more conversations such as this, to discuss the implications of diversity, equity, and inclusion, or DEI, in the clinical research space. We are also evolving our I Participate patient public brand into a bona fide nonprofit that we hope will allow community stakeholders to interact in this space in more meaningful ways. The long view is helping industry to be better able to fulfill obligations and opportunities to share the wonder and the hope of science with the broadest possible patient audience. That said, I do firmly believe that all sectors and all individuals have a role to play in shifting this paradigm, that none of us has the luxury of being bystanders, of being mere spectators who say, I'll wait and watch and see what happens. No, the fierce urgency of now makes this an all hands on deck proposition that necessitates our input in ways you may not have envisaged. But never fear, I am nothing if not full of ideas and suggestions. And you've made inquiries into any of these things, then bravo to you, I say. That's fantastic. But at this point, let's look at broadening your impact and revisiting it. To make the changes that we need to see, to move that proverbial needle, and to see measurable improvements in diversity, equity, and inclusion, we have to include a more representative sample of the population to the participation table. But to do that, we're going to need you to include more public relations and health communications focused there as well. In the US, there is a long-standing National Institutes of Health mandate for the inclusion of women and minorities in any clinical studies supported by federal funding. Actually, the Revitalization Act harkens all the way back to the early 90s, now almost 3 decades ago. To date, this mandate has been nearly an ideal in that it continues to lack accountability, consequences, or teeth. As a public relations specialist, are you aware of this? Have you ever made inquiry about it? You know, this applies to people who are in the US. Or have you ever interviewed anyone about any of the regulations that underpin clinical research, or how these regulations impact diversity and minority inclusion today? We need more public understanding of these issues. And as you pursue stories, be cognizant of the fact that it's patently impossible to achieve equity in healthcare without first ensuring equity in clinical research. The former is the effect of the latter. There is no such thing as equitable access to care in the absence of equitable representation of people of color in the clinical studies on which the evidence is supposedly based. But we are still far from adequate patient sampling in clinical trials. Is it really a leap to suggest that prescribing medicine to patients representing demographic groups who have not taken part in the evidence gathering part of the equation amounts to shooting in the dark. Patient diversity in clinical trials is essential to scientific integrity and the broadest marketability of drugs and devices and other discoveries. But special populations have posed significant recruitment challenges for investigators, as you probably know. Participation is lowest among minorities, with whom research has earned the repudiation of being exploitive and abusive. Tragically, negative perceptions about science are most pervasive within the communities for whom medical advances can't come soon enough. Cue a pandemic that not only preys on frontline workers, but also those who have disproportionate prevalence of pre-existing conditions.
12 o'clock.
Obstacles to robust representation in clinical trials seems omnipresent. It is like the water in which we all swim. But that water also contains the historical atrocities and institutional racism and a general lack of equity in access to care. The growing urgency for vaccines and remedies to a pandemic are now just piled up on top of the discoveries that can address the pre-existing conditions and the persistent health disparities in special populations. And as we see right now, the most advantageous scientific breakthroughs risk remaining elusive in their access and in their application in the absence of trust and understanding. You are urgently needed as the couriers of better, more balanced messaging that includes more voices and that will lead to more representative study participation. So whether it's a new drug or a new device or nanotechnology, whatever it is that is being developed, being able to demonstrate its safety and its efficacy and usefulness across the broadest market possible, as well as precision medicine micro markets, is riding on the recruitment of as many patient subgroups as possible. Doing so on those populations being able and willing to digest content in a meaningful way, and on science being challenged by you about the innovation of the messages that it crafts about itself, about how it explains itself to non-scientists. That, again, is where you as public relations and communications specialists fit in. Accessibility of better healthcare isn't only about availability, location, or transportation issues. It's also about perception and changing that narrative. Certainly, if you are unfamiliar with its source or not trusting of its content, you won't access it. You simply won't get the relevance it has to your own life. Deliver content, please, that awakens the imagination. Even with the advent of decentralized trials, defined as those studies executed through telemedicine and mobile or local healthcare providers, collecting data remotely, or what else, other things that don't otherwise fit in the traditional study model by virtue of a heavy lean on technology and fewer live visits to the study site. Even with virtual trials taking a real stronghold in the age of COVID, there will always remain a huge need for human engagement and evolved communication. I would also submit that the need to communicate better with patients and the public demands that it be done even better now. Just because technology and automations are making trials virtual and quote unquote less burdensome, this does not mean that people will automatically line up to take part, as we've seen. The fact is, investigators, sites, clinical research organizations, or CROs, and sponsors too, clearly need your help pushing out cogent information that describes how clinical trials work They need your help connecting those dots with how research impacts care, as well as how the process is regulated and why oversight is actually different today than in years past, which is a particularly keen message that's needed for underrepresented patient markets with long memories. And to be clear, for industry's sake, bona fide inclusion is just good science, as it ensures against patient shortfalls that too often lead to studies being shut down early for lack of participants. The economics of starting the recruitment plan early that recognizes the appropriateness of focusing on diversity deserves more public discourse. You can make that happen. A worst case scenario involving lack of inclusivity is experiencing side effects that were indeed foreseeable, but for lack of equitable participation in clinical trials. We don't want to be talking about premature approvals and commercialization, there we go, of things that were pushed out to market too soon when they probably needed more testing in the actual patient populations that might be using them. Industry tries to avoid, as a rule, black box warnings, likewise class action lawsuits and product recalls. So if clinical research is supposed to bring forth the promise of cutting edge medicine, its integrity is compromised by homogeneity, and equity in health outcomes actually then becomes a moot point. As significant players in this space, know that you can help bridge the chasm between underrepresented populations and science by featuring stories that broaden the scope and include a broader sample of voices and participants. Even if you think that DEI is not the central focus of the story, I urge you to reconsider, to recognize the places where it might be hiding, where it might be dangling in suspended animation. Press for answers to what DEI issues might be lurking in the shadows. Think in terms of DEI being intrinsic to any story, even in unanticipated ways. How does DEI impact an entity's patients or customers, their margins, their markets, their workforce, corporate culture, training of the corporate culture, branding, their SOPs, the integrity of their data, and the application thereof? And regarding entities actually conducting research, if the design and performance and data points of clinical research are not robustly inclusive, what's the point really? More discussion of these issues in general makes us all better prepared for being our most diverse, equitable, and inclusive. And prevention is worth so much more than scrambling for a cure. If we communicate better and earlier, and when not in crisis mode, we all gain. Our ability collectively to move the needle and make studies more representative relies on bridge makers that can nudge deeper understanding and harness the courage to raise necessary questions, providing new platforms for community engagement and delivering on more research literacy to the public, and offering hope by connecting the dots for more people. Communication specialists have a lot of power, and with great power comes great responsibility in establishing new norms. When you're pursuing stories and exposure, decide to take a different angle. Be on the lookout for more solutions to problems and the people who are actually making a difference. We've had quite a lot already on identifying the problems and gaps. We already know those things. Not enough coverage on people who are making inroads that can change the outcomes. Feature them instead, and multiply and magnify the ubiquity of clinical trials. Help our research naive public to better make informed decisions and contribute to their awareness of clinical trials and the level of research literacy that's needed in patient communities. You might feature people and organizations that don't typically get a lot of press, but who are getting the word out in their communities and being good community partners. Speak to minority patients and scientists and institutions who are actually involved in this, grinding away, who are in the trenches. Publicize their stories. I plead with you to openly challenge the concept of what, quote unquote, evidence-based medicine truly is and what it is for all of us. Push back with regulatory boards and entities. Ask them for more thorough explanations regarding the approval processes that take place all along the study life cycle. The public needs to know if, when, and how protocol approvals take place, especially in the absence of diversity, equity, and inclusion. Ask the hard questions. You're essential interpreters. Help the public to better grasp how the process works, to explain what patient protections are actually at play in your country's system of drug development. But regardless, bring more attention to the importance of the public's participation. We need you as translators and interpreters of health information and medical jargon. You are essential players. Changing the clinical trial landscape to make it representative of real people requires more accountability across the board. Interview investigators of color and those investigators in charge of studies that by definition impact and should include patients of color. Find out what their take is. Interview doctors of color who are not investigators and inquire about their personal take on clinical trials. Do they harbor culturally based misgivings? I would say routinely ask physicians, not to mention healthcare providers who are people of color, how often they themselves are referring their patients to clinical trials, under what circumstances, and toward what end this is taking place. Likewise, ask patients about the extent to which their providers are even bringing up the issue, the topic of clinical trials. And if so, what that looks like from the patient point of view. We are counting on you public relations professionals across health sectors to probe more and to sample more and more broadly. You can produce balanced exposure that can directly reverse lack of understanding and can help make the vernacular of clinical trials rightfully more commonplace and more acceptable, and demand more transparency and accountability on the part of industry. We're counting on you. Thank you so very much for the work that you are doing. And it must be said that it's not going unnoticed. Please reach out to me through Ishtar and the organization if I can be of any help. Thank you so very much.
Thanks, Allison. I didn't think that I was going to hear the hot tip of creating content that tickles your senses today, but I love it. And I will be taking that away. So thank you.
Thank you.
I'm going to open it up to our panel discussion now, but I might just ping back to Leontina with a question around, if you could unpack a little bit more what you're doing with the tech industry to ensure that equity, diversity, and inclusion are really at the heart of health tech design. So can you tell us a little bit more about that?
Yeah, no, absolutely. Really great hearing David and Allison's presentations, a lot to learn. But yes, absolutely. So I mentioned at the beginning our work with the Shuri Network and how we're aiming to connect leaders from the tech industry with members of their network from across the health service and informatics and in digital roles. But there are a number of things that TechUK is doing across the organization and working with our members, and this is led by our Skills, Talent and Diversity program, where essentially our aim is to ensure that the UK has a world-leading tech workforce, that we're supporting and building a pipeline of talent that is equipped with the digital skills that are needed for the future, and that we're attracting and retaining a diverse workforce. And something that we often emphasize, so particularly during COVID-19, we see that some companies feel like they might have to remove diversity and inclusion from their list of core priorities. But I think it's actually crucial that instead they should be at the top of their agenda, because this will be crucial for their business success. So there was a report published by McKinsey last year that showed the business case for diversity, equity, and inclusion, if we ever needed one, was stronger than ever. It found that companies with diverse teams, both in terms of ethnicity and gender, were more likely to outperform companies in terms of profitability than those that didn't. There's also a risk that companies might feel that this is something that can only be addressed by large multinationals that actually have the financial resources to address these issues accordingly, and that can afford it. But we actually know, as Alison mentioned, that this starts with the culture and the leadership that you instill in an organization. So to give you an example of what we push for, so at TechUK, we encourage our members to become a signatory of the Tech Challenge Charter, which some of you on this call may have already heard of or be familiar with. So the Tech Challenge Charter is an organization that aims to address inequality in the tech sector and to drive diversity and inclusion in a way that actually can be measured. And so those that sign the charter make a number of pledges regarding their approach to recruitment and retention, and they also must commit to submitting diversity data every year, which we believe is extremely important because we can only support policymakers with good quality, comprehensive data to make the right decision that address the needs of the populations we are talking about. And so this is one example of what we encourage members to do, but essentially we believe this is important because we otherwise, as David has mentioned, risk perpetuating historical biases. And this could have an impact not only on us at the moment, but also future generations, and could lead to further disparities, reinforcing privileges and so on. I don't know if you're familiar with Caroline Criado Perez, who is a famous journalist and author and activist. She published the Invisible Women book back in 2019. And I attended a conference last year where she gave a really interesting example of a study, and I believe it was from the University of Washington, where she mentioned that a study that used a data set with deliberate bias, where pictures of cooking were included over 30% more women, and so found by the time that algorithm had finished trading, that number had actually gone to nearly 70%. So the bias, meaning it was actually confusing men for women just because they were sitting next to a stove. So I think that's a really interesting example, and I'd love to hear more from David as well of what can be done essentially to address this, and perhaps as well TechUK as a trade association, what we should be pushing our members to do in order to make sure that this is at the forefront of their agendas.
Yeah, I think that's great. So thank you. I will just toss it to David to see if you wanted to add anything there. But also, I think that feeds into something that we had talked about when we connected previously, which was around, how can people be empowered to democratize the data? Obviously, companies nowadays are collecting so much data, especially in the healthcare sphere. So how can we use that, as you say, to and analyze it and use it for good, rather than kind of being dictated to, as you say. So yeah. I would welcome your thoughts on that.
Yeah, I think, as I said, we're all capable of knowing these biases, right? Or being exposed to them by experts, and so I think it has to start with theory, right? For example, my team are data scientists. We don't know the theory, and we don't claim to be specialists in any industry, healthcare included. So I think it's about starting with the experts who already know that foundational bias that could perpetuate into the data as we collect it, and ensure when we collect that data that we make people aware of those biases when they're labeling, right? So it's not just who and having a diversity of people that actually create those labels and provide those opinions so that our algorithms can learn from them, but it's about educating them before we do that. I think from a tech perspective, and some of our clients are pushing tech providers to facilitate this, is enabling people who care to have that impact of saying, no, this this algorithm is wrong, or this is bias, and allowing people to contribute positively to the collection of the right data that has the right labels. And so there's a few instances of situations where clients have devised an approach where they've said, look, we're going to create a button, for example, where you can tell the algorithm where it's wrong, right? And so algorithms have an ability to learn, almost in real time from what you tell them and indicate to them. So I think there are certain areas where there are big gaps, and I think we all know where they are. And in everyone's respective areas, especially, you will know where there is a bias. Even in like we just heard, the trials and the exposure to trials of different people. So we know where those gaps exist, and we have an ability to positively contribute to the collection. I mean, for example, patronizing and condescending language. I think it came up at some point in this chat, but doctors and nurses and the way they communicate, and I think we'll get onto COVID and hesitancy of vaccines, I'm sure, in the discussion later, but it all has an impact. And if we can collect data to help us identify, for example, patronizing language in different scenarios for different people, especially in the healthcare space, then we can train there's a big drive at the moment in AI tech healthcare as a service, right? And if we can make sure that when we implement those services, that before we've done that, we've already prepared for instances that we know will come up where bias could exist or negative impact could exist because of use of condescending language for different people and whatnot. If we prepare ourselves and collect the right data and make sure that when we speak to our tech partners or we train our own algorithms, that they are considering what they should be considering, I think it's just a case of standing up and we all have a voice and we all have the right to say this is wrong. And I think that's what's really powerful at the moment, that there is a big uproar, but I think people don't realize that they also have the ability to have a positive impact in helping us to collect the right data and provide the right direction for AI. So yeah, hopefully that wasn't too much of a rant, but yeah.
No, I think that was really, really good. I think you're right. I think diversity as a topic and diversity in healthcare can seem very broad. And so it is, I think it's really important that we can focus on things that, individuals can do, not just, within a broader organization, but also, at the personal level to help take these things forward. So I think that's really important. We've actually got a question here in the chat. It says, I work on a social care, a national attraction, recruitment, and retention campaign, and we struggle to reflect the wide range of communities in our country in our campaign. This is a huge issue as people need to relate to the stories for them to consider a career in care. We struggle to find people who are already working in care and are willing to share stories. Do any of the panelists have any recommendations to improve diversity in our campaign? Maybe we're looking in the wrong places. And I think maybe this is, ties into Allison's point earlier about working hand in hand with community organizations. So, if you're struggling, I might just throw to you, Allison, to comment on that. But that when I read that question, that's where my mind went immediately. So I wonder if you have anything to add there.
There we go. The short answer is no. You covered it well. I would have echoed the same thing. Check in with community-based organizations. Check in to see what's going on in the trenches and on the ground. Reach out to people who have something to say and have not been given a platform before. And you'll be surprised at how much more intel you get, how much the sources will reveal to you.
Yeah, and I think there might be something there as well, perhaps around unpacking, like what are the barriers to them wanting to participate, or wanting to share their stories, like what is stopping them from being involved. So perhaps
Right.
that so conducting, as you say, to your point about interviewing clinical trial leads, or even people who aren't leading clinical trials, and why aren't they, doing that, and those investigators. So I think the same point could be said here. If people are not wanting to participate, kind of what is the hurdle, and it's only once you know what the hurdle is that you can actually kind of tackle it, I guess.
Absolutely.
Yeah. Leontina, any thoughts there?
Yeah, no, I completely agree. I think it's important to understand what the barriers are and then tailor your response accordingly. I'd be interested to hear more about the campaign, though, and see if I could connect the person that asked the question with my colleagues that lead on social care, and to see as well if you've been speaking to Health Education England and other bodies actually that work on this to get their view too.
Wonderful. I have a question, and I think this might go to Leontina and David, both of you. But kind of what does digital transformation with diversity and inclusion at the core really look like? And can you give us an example of where you've seen this done really well? I might look at you, Leo, first. Yeah.
Yeah, sure, no problem. Yeah, so actually, Tech UK recently published a 10-point plan for health tech, which is a new report outlining 10 recommendations to strengthen the UK's reputation for health tech. And I can share the link with the attendees if it would be of interest to take a look at. But it focuses, our recommendations focus on a number of things that you'd expect from us. So putting the power into the hands of the public, but also attracting, investing in, and retaining a diverse workforce. And so supporting initiatives like what I mentioned, the Sure Network will be crucial, but this also needs to come from the top in every organization, every team, and for everyone to recognize that it's crucial if the NHS is to transform the way it delivers care. In terms of the examples, I recently came across one from focused on digital inclusion from Scotland. And it's called a Connecting Scotland program, which aims to support the 800,000 people that are estimating to be facing digital inequality in Scotland by providing access to equipment and connectivity, but also aiming to build up their confidence and give the knowledge required to use those technologies. So I think this is a really interesting example, and it's also something that we call for in our report. We talk about how it's important to ensure that any efforts to drive patient engagement, as we've heard throughout this session, needs to address the digital divide. I think the ONS, or figures from the ONS, indicate that 1 in 10 UK adults did not use the internet in 2018, and over 4 million people are estimated to not have any basic digital skills. And although we're seeing progress and that number is improving over time, we need to ensure that the introduction of any new services actually meet the needs of those that might be most excluded, but actually, as Alison was saying, might benefit the most from what digital has to offer. So that's what I'd say.
It's a really good point. I think of that. I was thinking about that the other day in terms of, something like a Babylon, or, an app where, everything is digitized, and, for someone who is part of the digital generation, that's super easy, right? And that's making our life easier. But for someone who is not, or is not used to smartphones, or, uses those on a very limited basis, like that's actually making it a lot harder for them to access the care and services that they need. So I think it's an interesting perspective, and one that I think does need to be considered, because a lot of the time when we think of digital transformation, for us that's a positive, but there is a portion of the population that's definitely it isn't in that way. So I think that's a great point for sure. Maybe if we come back to David's point earlier, around the impact of this type of biases on something like the COVID-19 vaccines, and trust in vaccines, and uptake of vaccines, because obviously that's really topical. I wonder if you wanted to comment a little bit on that. I think you had something something to say earlier, David.
Yeah, I think just to build on the transformation piece, and the theme that I'm kind of trying to land here, which is data really, and data is the part that really impacts the AI, right? And I think when it comes to transformation, that there's a centralization of data, and there's also an awareness of where we can look. I mean, there are places outside of the realms of day to day that you can look to answer these questions. And I mean, one of the things that jumps to my mind, especially when we think about the COVID vaccine, is misinformation or disinformation, right? And how it travels and where it travels and who it impacts. And so that kind of let's look at information, you know, outside of what we have in our walls and what we collect, and try and look at the impacts across different groups of people. You know, misinformation is huge when it comes to vaccine hesitancy. But I think pairing the two, right, that where to look, but also what to look for, you know, like knowing that there are historic hesitancies because of treatment in the past, right, of less representative groups, is how you connect those two things. So I think just listening and knowing where to listen to what people are saying and why they're hesitant when it comes to the COVID vaccine, and linking it back to more of the kind of behavioral psychology side, behavioral science side. So I work very closely with our behavioral team, and they look at it from a person perspective, right? And I look at it from a machine perspective and a scale perspective. But we have to try and understand the why behind hesitancy. So we're doing some work at the moment with a company called Receptivity, and we're partnering on sort of computational linguistics and understanding what it really is when it comes to hesitancy. Like, people say they're hesitant, but going one level deeper to understand which are the real drivers, and which is emotional and which is functional, and how we combat each of those things, and then, you know, which of those is linked to misinformation, and then how do we line that up to the correct message to give that person to change the way that they are hesitant, or why they're hesitant. And by the way, if anyone wants to just have a chat to me about where to look for data, or, you know, how to think about these things, just give me a bell. I'm happy to help, because I think that the challenge is that there's kind of two worlds, and I'm lucky that we've got both sides in Adam and DXI, but sometimes you don't have that. And I think just being able to connect those dots that are outside the realms of maybe the industry that we're talking about here, it's a bit, you know, it's a bit difficult sometimes. So and we have to solve this together, I think. So again, I rambled. Apologies for that.
But David, I will say that you've taken the first most important step, and that is to be cognizant of it and to start there with questions and not presumptions. So bravo. Carry on.
Definitely. I was gonna, you took the words right out of my mouth, Alison. I think that the first, the word that David used was around listening, right? And I think that's the key piece, which, sometimes just gets missed because we're so in healthcare, we're so focused on the solutions, but like we haven't even really figured out the problem correctly for everyone at the beginning. And so I think, that is a really important step. And I was listening to at another recent conference to Simon, who heads up the comms for the NHS. He was talking about some of the work that they've been doing with minority ethnic communities around the vaccine and around COVID-19 and education, talking about, there are no animal products in the vaccine, that there's no live vaccine in the vaccine, there are, that it's halal, that, so speaking specifically to concerns from those individual communities, which really is helping to drive uptake of the vaccine, and combat hesitancy, but without speaking to those communities and understanding, what is the barrier there, or what are their really their concerns, you won't be able to do that in the comms. And so I think that, they did a really important piece of listening as well, and I think within something like a COVID-19, you're kind of moving as quickly as you can, but I think that's a really important thing not to overlook. Leontina, any thoughts there?
Yeah, no, completely agreed. And actually, I read a recent editorial in the BMJ, which it pointed out exactly what you've just mentioned. So it's important not to dismiss or ignore any concerns that some ethnic minority groups might have about vaccines, but actually engage and listen carefully and, you know, understand what those are. It could be side effects, or it could be long-term effects on health. And so essentially, I know they point out for the crucial need for effective public health messaging that reaches those communities. And a comprehensive strategy that actually addresses the different concerns that we see behind vaccine hesitancy. And so that could include, which you mentioned at the beginning, you know, providing educational resources in different languages about vaccine safety, vaccine efficacy, but also on the government side or on the NHS side, you know, making vaccination more convenient and more accessible. But the most important one, as you say, is, I believe, is listening and understanding the issue carefully and then offering support according to that. I also agree with David that it's important to address the misinformation piece. An example I saw from at the beginning of the year that the NHS was using influencers or community leaders, trusted community leaders from ethnic minorities to debunk myths around the vaccine. Whether that works, you know, it's a different question. But I thought that was pretty interesting. So just, you know, building on that trust piece, which is key.
Definitely. And I think, you know, I love that you brought up the influencer piece, because I think that, you know, what I love for our audience to have is some key takeaways of things that they can really do, right? Because I think this is a topic where a lot of the time it can feel like a lot of talk and not a lot of action, which can be a bit frustrating. But I think for things like influencers and spokespeople, when you work in comms, that is something that you have a lot of control over, and who you're putting forward for interviews or who you're suggesting for speaking engagements, or, you know, and things like that. And so, you know, or your influencer bench, who you're suggesting, you know, and looking at the diversity of the mix. And so I think that's a great shout there in terms of something that people can think about as a real tangible, you know, takeaway. There's another question around, are there any companies or organizations that you think are taking a proactive approach to addressing bias in their clinical trials or follow-up studies? So Allison, I might throw that one to you.
There we go. I'm not quick with the mute, unmute button. I did respond to David. I'm sorry I didn't respond to everyone. That I'm probably a bit biased in my recommendation because I serve on their patient advisory council, but I'm working closely with a company called Medable, and they are tech-based as well. So what I'm really impressed with is how eager they are to take in data from unpopular, perhaps, or typically overlooked sources. They focus a lot on perspective from patients. They focus on being very patient-centric, and with that comes attention to diversity, equity, inclusion, removing biases, and so forth, and recognizing those things. And in effect, retraining industry to recognize that it's implicit quite often, more often than not, probably unintentional, but that it needs to be discussed, and that we can be grown-ups about it and not get our feelings hurt and not, you know, cower in the corner for fear of some kind of retribution, but that this is all worthy discussion to have.
Mm-hmm.
And if I come up with other ideas, I'll let you know.
And do you think, or have you seen, I guess, over the past, you know, couple of years, that the appetite for doing that has increased? I guess, you know, as we've seen, you know, the diversity agenda has been elevated immensely over the past 12, 18 months, you know, which is great. But I guess, you know, hopefully that momentum can continue. And I'm wondering if you're seeing that reflected in the companies that you're working with, or the, you know, within your work, and I participate in, you know, that kind of stuff.
Well, the discussion has definitely been elevated. You will pardon me for being a bit of a skeptic in terms of how the longevity of it plays out. Not only the longevity, but the actual practicality, the application of these promises, of this new acknowledgement. For so long, these issues were not a secret, you know, issues of disparities specifically. They haven't been a secret. And I don't want to make it about the work that I have been doing per se, but it's been a struggle at times to have companies that should care and should be making things more patient friendly and more transparent and starting earlier for the planning of diversity in their patient recruitment, but lacking in the follow through. So I'm waiting to see what the follow through is going to look like, and to what extent the services that are provided vis-a-vis trials and protocol development is going to be inclusive of people's opinions early on, when it can make a difference in the design of these studies. Because so often barriers are baked in to the way that the protocols are developed in the first place.
Yeah.
And then they don't call anyone to help them out until, oh, could you come and rescue us, please?
Mhm.
Could we
I
get
was
a
gonna
little help?
ask, like, how much of that is this is how we've always done it, so this
Oh
is how
yeah.
we'll always do it,
Oh yeah.
you know, versus like, you know, because it's the path of least resistance, right? I guess.
Bingo.
Yeah.
All of that.
Yeah, and I
All
guess,
of
you know,
that.
it takes you know, a real shift in how things are done, and a reframe, and a lot of work, I think,
It,
especially in
it
clinical
does.
trials.
All of that. Absolutely. And it sometimes boils down to a control issue as well. A lot of times companies don't want to relinquish control or to acknowledge that they don't have the answers to a particular quandary, and that they should resort to the expertise of those who have the disease, who are in these communities, who have a vested interest in the process and in the outcomes, and getting involved with them earlier on. And furthermore, it's not enough to be invited to sit down at the table if you don't have any decision-making power. So work on listening, to David's point, and then work on implementing the recommendations that you're getting from this invaluable intel in the community on a group basis and on a patient by patient basis as well. Everybody's got something to say, and the more you hear from them, the more vested they are in whatever it is you're trying to sell them. They feel like they are respected.
Yep. Yep. We've got one more question here, which is, what are the longer term trust building activities that companies should be involved in to reach these groups outside of high level awareness campaigns? So I might just start with Leontina and kind of go down the line.
No, I think exactly as you say, so supporting local champions, faith leaders, I know healthcare professionals as well, because they are, you know, among the most trusted groups. So I think that is very important. That's the approach that the NHS, as I mentioned, was taking, or at least that I saw at the beginning of the year.
Great. David, anything from you?
I think I'm not sure this is my area of expertise to answer this, but I think just talking to them, you know, I think the acknowledgement that people are being heard, and that they're being represented, you know, so that there's a way to ask people to contribute, but then we have to tell them that they've made a positive impact on how we're changing what we do and how we learn, and ultimately how we impact. So, and I think sometimes that's missing a bit, the impact that the people have had, and because it has a circular, you know, snowball impact, I think longer term, to getting people interested to do more and help this problem. So yeah, this.
Great.
Amen. You got amen from me, David.
I was going to say, Allison, anything to build on that?
You see my head bobbing.
Yeah.
I'm trying to keep it on my neck. Everything David said is so true. Making sure people know that they're being heard. And the fact that the feedback needs to be circular. There needs to be a loop. You need to circle back around and confirm with people that they have been heard, that you have taken on their suggestion that it looks, that a campaign, for example, looks a certain way because of their impact, because of their input, and then get feedback from them on that product. And they'll say, oh, that looks great, or oh, no, that's not what I meant at all. And where are you going with that? But just to keep them involved is golden, and it's absolutely essential, absolutely essential. And I would also add that the hurdle of trust, it gets talked about so often that it's almost cliche, but I will say this, and meditate on this, if you will. If you build in transparency, you don't need to focus on the trust as much. The trust will come. If you let them know, if you let people know what's involved, why their participation is relevant, what they have to lose, what's at stake, all of those variables, and allow them to weigh in. Don't be presumptive about what their hesitancy is, because you may never know. In some cases, I would say prior to COVID, prior to the pandemic, I was always saying, don't presume that minorities are unwilling to participate. You haven't asked us properly. That's the issue. Once you create the best, most customized, most culturally competent and relevant invitation, and you send it out and you still don't get the response you're looking for, then we have problems. But let's start with creating the most appropriate invitation to the table, to the process first, and see where that gets us. Because it was clear to me, it wasn't a presumption, that industry was using that unwillingness moniker as a crutch.
Yeah.
That they were willing to leave it at that. Oh, you know, the past, Tuskegee, that was the buzzword always.
Yeah.
But transparency. And acknowledge the fact that, I mean, it's called research for a reason. We don't have all of the answers. That participants are essential research partners. Treat them as such. Treat them as such. Don't discount their invaluable contribution. And, you know, I could go off on a tangent, can you tell? That the
we have 15 minutes left. On you go.
I don't want to hog it all, but you know, I would just say it's a transparency thing, it's a respect thing, and don't assume. Ask more questions and then listen.
Yep, I love that. The two T's, trust and transparency. So I love that. I know we're kind of winding down in terms of time, but I wanted to kind of close with asking each of you the same question. So I might start with Leo, and it's, if you had one takeaway for our audience today on something tangible that they could do to take this discussion further and further the diversity agenda, what would it be?
I'm keen to hear from Alison and from David too, and from you. But no, if I had to give one key takeaway, is something that we often say at Tech UK, is that we all have a role to play. And I think, Ishtar, you've previously mentioned in some of your social media posts, you know, diversity matters for everyone. And clearly this is not a new issue. It's just been brought to the light, given the impact that we've seen from COVID-19. But I think my key takeaway would be this: just think, each and every one of us should think how we can encourage diversity and inclusion, listen carefully, and then use the resources that we have and the privilege that we have to drive the change that we do want to see, while also recognizing that diversity, equity, inclusion, they're not tick box exercises, they're not, you know, one-off activities. And so this is what I would say. But I would love to continue the conversation if anyone is interested in finding out more about the work of Tech UK and the Skills, Talent and Diversity program as well.
Great, thank you. David, top tip?
I would say that each and every one of us has the ability to make things better. You know, from my perspective, there is a bias that exists in AI right now. There is. I mean, there's a bias that exists in, you know, healthcare in general. We've talked in depth about that today, but we all have the ability to make an impact on how algorithms can learn, and that starts with collecting the right data and asking the right questions and highlighting the problems that we should be looking for and sourcing and serving up. So I would say push people like me and others that love AI and love data science and love the things that you know are the things that are impacting bias, and go to them with your problems and say, look, I see this problem, can you solve it? And I guarantee you that people are so interested in this, that have those skills, have that awareness of data, that they'll go, all right, let's have a chat and let's try and solve this together. So ask questions and challenge us, because I tell you now, on the data science side, I've been on so many dry, boring, transactional, turnkey projects that don't have an impact on the world, that ultimately don't do good, and I can't tell you how excited I am when people come to me with problems like this problem we're talking about today, that I can help with, that you can help with, and we can contribute towards together. So and I'll share a little example of a link in the chat here. I've just one that I stumbled across, which is helping to collect the right data for the right cause, and this one is specifically around skin and removing the bias of how we diagnose. And it's just one example, and there are tons of these examples where we can all contribute, and we can get our friends and families and patients to contribute to collecting the right data and then positively impacting the services that we build. So push your tech partners, push your data scientists, push everyone to improve this together. So yeah.
Great. I love that. Thank you. Allison, hot
I do
tips?
too. David, you and I are going to have to talk about you taking my sound bites. I completely agree. My takeaway, now that my other one's gone, is that if you want to ensure that you're not complicit in a one-sided narrative, it's time to examine, I'm going to sound repetitive, it's time to examine who's on your invitation list. Who are you deciding to interview and to quote? Expand that. I challenge you to do that. And challenge yourself to be willing to pursue unique, rarely seen perspectives on issues. Take more risks to broaden your reporting on that truth. I would also reinforce this as well. And many of you are probably already on it, but that is, whenever you're discussing a specific therapeutic area, do your homework about who that disease affects and whether, to what extent, I should say, disparities are at play, how it affects what population, and how a medical breakthrough in that area would impact those disparities, and talk about that. Do a deeper dive into that and how that impact would benefit those populations who might take part in those studies. So make, again, connect the dots.
Yep. Great tips. Thank you. I think I've really, really enjoyed talking to all of you guys today. So thank you for sharing your insights. I know all of you have said in different ways that you'd be happy to kind of continue those conversations with people afterwards. So we will make this recording available for anyone who missed it, but we'll also, be sharing resources afterwards as well. But I might just to say thank you for joining us, and hand over to my co-chair of the PRCA Health Group, Matt, just to say a few words to close us off.
Thanks, Ishtar, and thank you all for a really fascinating discussion, some great perspectives. It's always really good to get genuinely interesting and interested people to come and speak to us. So thank you very much for doing that. Also, thank you to our sponsors, Vulio, for sponsoring our group for this year. We've got another really exciting packed schedule of events coming through as well. And we really want to call out to any of you who are still watching, listening to, if you've got a topic that you'd be interested in us covering, or if you would be interested in getting involved with the health group itself, please do contact us personally or through Kieran and the PRCA groups. We'd love to get you involved. And then just finally, also just watch out for further details of our annual conference we'll be following shortly. Well, thank you all for joining us then.